Good morning, everyone, and welcome to today's virtual rheumatology practicum. Just a couple of housekeeping items before we start. If you could, please type all questions into that Q&A section rather than the chat section of Zoom. These questions I'll be moderating throughout the talk, and I will present those to the speaker at the end of the lecture. None of these questions are viewable to others, just to myself and also our host. So please feel free to ask away. It is my pleasure today to introduce Dr. Ankoor Shah, who will be giving the lecture on scleroderma. Dr. Shah is an associate professor of medicine at Duke, where he primarily focuses his practice in the Duke Scleroderma Center. Here, he sees patients and has worked on several clinical trials as well, and focuses on expanding the role of stem cell transplant for scleroderma. Dr. Shah is also the section chief for rheumatology at the Durham VA Medical Center. Dr. Shah, I'll turn it over to you.
Good morning. Thank you for that lovely introduction. My talk today is on a topic near and dear to my heart, systemic sclerosis or scleroderma, the basics. This is really the Scleroderma 101 talk that I like to give. And these are my disclosures. I'm the PI for several trials. So the objectives today of today's talk is really to provide an overview of the presentation of systemic sclerosis. We really want to review the key manifestations of disease and treatment, focusing purely on skin, vascular, lung, and GI disease. We'll then explore the algorithms for treatment and directions for future research. So what is systemic sclerosis? And through this talk, I'll use the terms scleroderma and systemic sclerosis somewhat interchangeably. The definition of systemic sclerosis is that it is a rare autoimmune disease. And I've put together this little schema to sort of describe the pathogenesis very briefly. There is a genetic susceptibility to the disease, and that's one that is still an area of research, and we don't know much about it. But it really affects the small vessels, and it's purely a microvascular disease where we have the key players being fibroblasts, collagen, vascular smooth muscle, and the endothelial cells of the blood vessels. Through a number of complicated mechanisms, we see autoantibody and cell-mediated damage to the endothelium, which then causes damage and apoptosis of the endothelial cells, and through that process, an accumulation of myofibroblasts around the blood vessels. Finally, with overproduction of collagen, we'll see end organ damage. And there's clearly a lot more to the pathogenesis of this disease, but that is sort of the basics of what's happening in the blood vessels of the major organs involved in scleroderma. A little on the epidemiology, and to review a great paper that recently came out in Rheumatology last year. It really went through a systemic review throughout the world of the incidence and prevalence of the disease. This is the most up-to-date numbers, but really these numbers haven't changed over the last 20 years when other epidemiology studies were done. In North America specifically, the incidence is about 2 patients per 100,000 people per year. And the prevalence of disease is there's about 25.9 patients per 100,000 people. Again, this is a rare disease. In North America, the studies have shown that it is higher prevalence in the Black population compared to white. We can look at this throughout the world. In South America, it's a fairly similar incidence and prevalence. In Europe, perhaps a slightly less incidence and prevalence, but interestingly, this is seen higher in the southern countries. The Asian epidemiology literature actually presents a much lower incidence of 0.9 to 1 per 100,000 per year and a lower prevalence. And again, in Oceania, a fairly similar prevalence to other places in the world. And again, these numbers have remained fairly steady over the last few decades. In terms of gender, like all of our autoimmune diseases, minus a few, the incidence is much higher in women compared to men. And these numbers, again, have remained similar for many years. It's about 4 to 5 times higher in women compared to men, and that goes for both the incidence and the prevalence of disease. So let's start with the patient case. And this is a case that is a fairly common new patient case in my scleroderma clinic. So it's a 35-year-old female who presents to your rheumatology clinic stating that she was recently given the diagnosis of, quote, scleroderma. In terms of her symptoms for the past 1 to 2 years, she has noticed the skin around her hands and elbows getting tighter and stiffer. She's also noticed some increased indigestion and occasionally the sensation that food is getting stuck. She also had a history of her fingers turning white and blue in the cold for the past 1 to 2 years. So again, this is a fairly typical case of what I would say, just at face value, looks and sounds like early systemic sclerosis. But how do we think about it from a diagnostic perspective? Well, there's a couple different frameworks that I like to use. I split the disease into, as most do, into two basic subtypes, limited and diffuse. Limited used to have the acronym of CREST syndrome, but we typically use the phrase limited systemic sclerosis and diffuse systemic sclerosis. And what's the fundamental difference between the two? In limited disease, there's distal skin thickening. So this really involves just the hands and feet, maybe the lower legs, lower arms, and the face and neck. In contrast, the diffuse systemic sclerosis subtype involves skin proximal to the elbows and knees and the trunk. Patients typically will differentiate into limited or diffuse in terms of their skin tightening within the first year of disease. And rarely does a patient with limited disease progress to the diffuse form, although it can happen. There are other key differences between the limited and diffuse subtypes. In patients with limited disease, they will often have Raynaud's disease several years before developing any other non-Raynaud's symptoms, on average 7 to 10 years. In diffuse disease, I often see Raynaud's occurring at the same time that non-Raynaud's symptoms such as skin disease occurs. Renal involvement is quite rare and limited, and while it's still uncommon in the diffuse type, it has a far higher prevalence. Interstitial lung disease, again, can be seen in the limited and diffuse type, but higher in frequency in the diffuse type. In contrast, pulmonary artery disease is seen in higher prevalence in the limited subtype, but again, only up to 15% of patients will get this. GI dysmotility and GI involvement can happen in 75% or greater in both types of disease. The other distinguishing feature are the presence of autoantibodies, which we'll discuss in far greater detail. But in patients with limited disease, we more commonly see the anti-centromere antibody, whereas with diffuse disease, we may see anti-SCL70 or anti-RNA polymerase III antibodies more commonly. I will say, though, I have seen patients with limited disease and SCL70 antibodies and patients with diffuse disease and anti-centromere antibody as well. In 2013, classification criteria were developed. And again, like many of our diseases in rheumatology disease, we have classification criteria as opposed to diagnostic criteria. This provides, though, a framework for diagnosis, but is used primarily for entry criteria into clinical trials of systemic sclerosis. You can see here a number of different clinical features and a weight or score that can be assigned to them. In patients with skin thickening or tightening proximal to the MCPs, this is given a weight or score of 9 points. In the absence of any other disease, this is somewhat diagnostic for systemic sclerosis. In the absence of this, however, we look for other clinical signs. Puffy fingers or sclerodactyly can provide 2 to 4 points on the score. Fingertip lesions are also weighed. The presence of telangiectasia and abnormal nail fold capillaries, and we'll see pictures of this. The presence of pulmonary artery hypertension or interstitial lung disease, Raynaud's or autoantibodies can also provide a score. So Raynaud's phenomenon is the symptom that I talk about first whenever I give a talk or talk to patients about systemic sclerosis. And the reason for that is that it is the presenting symptom in 95% of patients with systemic sclerosis. And that's one key takeaway point from this talk, is that if a patient doesn't have a convincing history of Raynaud's, think about another disease that may be causing skin tightening, thickening, or joint symptoms. Raynaud's is caused by activation of sympathetic nervous system, leading to vasospasm in the fingers. Prolonged vasospasm can unfortunately lead to digital ulcerations. And here's a pretty clear picture of Raynaud's. And this is a picture that I will frequently bring up in clinic. When patients say, well, I'm not sure if my fingers turn blue. Sometimes when it's really cold, the fingertips will turn blue. This is Raynaud's, and it's very clear and it's not subtle. So if a patient, again, isn't sure about whether or not they have Raynaud's, I'll show them a picture. And if they say, oh, I get that all the time, that's clear Raynaud's, and they say, no, my fingers never look like that, then again, think of something else. Now, patients don't have to always have that classic triphasic change of white to blue to red. Some of my patients' fingers just turn white, although sometimes it will be blue. And sometimes patients with very clear disease, their fingers will be cyanotic in clinic. And of course, that makes the diagnosis somewhat easier. What we're trying to avoid with treatment and good care of the hands in terms of prevention of Raynaud's are ulcers and necrosis of the skin. This can happen, however, even with the best care, and can lead to infections, amputations, both auto amputations and surgical amputations. And it's not uncommon to see a patient who has had scleroderma for 15, 20 years who has had amputations of their fingers. Other skin manifestations, this is sort of the hallmark of systemic sclerosis or scleroderma, and this is tightening of the skin. And this patient has probably had disease for several years. You can see where the tightening has led to significant contractures of the skin. But if the pictures are clear, what you can see is this shiny, taut skin, a lack of wrinkles in the skin. And this is, again, the hallmark of systemic sclerosis, particularly of the hands. Commonly seen in patients, particularly with limited disease, is what's called a scleroderma facies, where they have almost what's described as a purse string appearance around their lips. And this is notable in the classic picture of scleroderma facies seen at the bottom right of this slide. Now, how do we define skin tightening? That is somewhat quantitatively, although somewhat subjectively defined by using the modified Rodnan skin score. This was developed by Gerald Rodnan, who was actually a former chief resident here at Duke in the 1950s. The way we do this is we split the body up into 17 different regions. Each of these regions, when you see a patient, is given a score. 0 means, well, this is normal. This is similar to the way my skin feels. 3 is I can't move the skin at all when I try to pinch it. 1 and 2 are somewhat in between. Each one of you that's doing a skin score will develop your own system for what you define as a 0, 1, 2, or 3. And the important thing is that you are consistent as you go forward and see this patient. It's not uncommon for another rheumatologist to come in and give a completely different score based on how they see things. The other source of differentiation between intra-observer variability is, well, let's just say you have an area of the forearm that's a 3, but the rest of it's a 2 or 1. What score do you give this? The way I was taught was to maximize the score. So that area of the skin is given a 3. Other people may average the skin or give the area that is greatest involved that score. Again, the most important thing is that you stay consistent with yourself so that you can determine change over time, both in clinical practice as well as in clinical trials. All that being said, the maximum score on a Rodnan skin score is 51. And I encourage you to try to do a Rodnan skin score with the patient gown at each encounter so you can get familiarity with how to do the skin scoring. Here are other skin manifestations. So telangiectasia, red violaceous lesions on the palms, on the hands, on the face, and the neck are the most common places, although you can see them in the mouth. So that's a good place to look for them. These typically do not go away, and they will increase over time. Other skin features, calcinosis, the C and crest. You can see these in areas of damage, such as the hands, but also areas where there is constant trauma. The waistline, buttocks, the elbows, these are common places to see calcinosis. So again, I encourage you to look everywhere for these. Now, we talked a little bit in the diagnostic criteria of the presence of abnormal nail folds. Again, this is something that can be done in the clinic, and there's a number of different ways to do this. The quickest and easiest way to do nail fold capillaries, in my experience, is using an ophthalmoscope. I use the ophthalmoscope and turn it to the highest diopter setting. I try to get the ridges of the nail in focus and then move it slightly proximal to the cuticle. And this is where you may see changes in the cuticle. In this slide, on the right side is what we'll call normal capillary changes. These are evenly spaced hairpin loops of capillaries. This is what you're looking for in quote unquote normal healthy patients. What we may see in what's called early findings are giant capillaries, and that's in the upper left box on the left. In patients with more active disease, you'll see diffuse enlargement of the capillaries as well as the presence of microhemorrhages. In patients with later disease or late stage disease, you may see actually dropout of capillaries or areas where there will be no capillaries at all, and even findings of what's considered neoangiogenesis, when you get these bushy, aberrant blood vessels. These can somewhat correlate with disease activity, although not perfectly. But again, I encourage you to look at all patients with scleroderma at their nail folds to see if you can determine changes. One other tip is to use Surgilube as a magnifier, almost the same way that we use oil immersion, to get a better look at the capillaries and also add contrast. The role of autoantibodies, again, I mentioned this earlier. We do see overlap between diffuse and limited disease, although again, in general, we see a higher rate of anti-SCL70 and RNA polymerase disease, 3 antibodies in diffuse disease, and anti-centromere antibodies in limited. 90% of or greater are ANA positive. In patients with anti-SCL70, it also provides some degree of prognosis. There's an increased risk for pulmonary fibrosis, digital ulcers, and cardiac disease. In patients with anti-centromere, there's an increased risk of pulmonary hypertension and digital ulcers, although somewhat protective against the presence and development of pulmonary fibrosis. In patients with RNA polymerase 3 antibodies, these patients actually have the lowest rate of pulmonary fibrosis, although an increased risk for renal crisis and gastric antral vascular ectasia, which we'll talk about shortly. Also importantly, there is a 2.5 times increased risk for malignancy. I treat my patients with RNA polymerase 3 antibodies similar to the way I treat patients with dermatomyositis, and that is I go screening for malignancy. There's no guidelines on how to screen for this. For some patients, that's age-appropriate screening. For other patients, that's a full chest, abdomen, pelvis CT to look for underlying malignancy. The most common malignancy associated with RNA polymerase 3 antibodies is breast cancer. So I do have all patients get a mammogram. Okay, back to our patient. So our patient had modified Rodnan skin score of 12, a normal lung and cardiac exam, although active Raynaud's, active telangiectasia, and normal nail fold capillaries. She ultimately had a positive ANA and positive anti-centromere antibodies, and you diagnose her based on the diagnostic and classification criteria with limited systemic sclerosis. Patient decides she doesn't want to start any medications now, but she would like to know if there's anything she can do to keep this disease from getting worse. The answer is yes. There's screening that we do. So what is the natural history of systemic sclerosis? Well, this is a fairly commonly used graph. In patients with diffuse disease, over the first 5 years, what you'll see is this relatively rapid progression of skin disease. During this period, they may develop GI disease, lung disease, heart disease, and potentially kidney disease. However, at about 5 or 6 years, there is this somewhat inflection point where skin disease tends to level off, and actually in about 2/3 of patients, it will improve. In patients with limited disease, there is again a slow progression of skin disease up until about 5 or 6 years, at which point it tends to plateau. At this point, the likelihood of developing lung disease is fairly low. Late in the disease, however, we can still see the development of pulmonary hypertension as well as GI manifestations, including end-stage GI disease and malabsorption. Here's a really interesting study done now about 5 years ago in about 700 European patients, which again emphasizes the point that many of the disease manifestations happen early in the disease course, although some can still be prevalent later in the disease. This study looked at patients from the time from the onset of Raynaud's phenomenon, and you can see the percentage of people that had skin involvement, a DLCO below 80%, and GI involvement rose rapidly in that first year and then sort of plateaued off. The presence of digital ulcers slowly climbed over that 10-year period. The development of pulmonary hypertension is defined by a PA pressure greater than 40 millimeters, again, slowly climbed in incidence over time. And the incidence of renal crisis, again, slowly climbed until about 5 years, at which point it leveled off. Mortality. Overall, mortality in patients with scleroderma has decreased over time. The 10-year survival still is about 66%, which is less than most of our other connective tissue disease. Of these patients that die, 55 deaths are due to scleroderma. Now, this is compared to a study done in the 1970s when the 10-year survival was 54%. So that is clearly improved, and some of that may be owing to dialysis in the patients that developed kidney disease. A 2017 study, however, showed that mortality in patients due to scleroderma has actually increased. They looked at the factors that could potentially predict an increased risk of mortality, and again came up with a scoring system that predicted 3-year survival. What you'll see on the right are the factors that contribute greatest to the scoring system. Some obvious criteria: being older, such as greater than 65 years old, having significant dyspnea, again, with the idea that that is related to lung disease, the same being the DLCO and FVC. What might be interesting to you is that the elevated CRP at baseline also contributes significantly to the overall 3-year survival. So this is something I do get when I see patients for the first time to help determine overall prognosis and mortality. Interstitial lung disease. This is very important because interstitial lung disease is more prevalent in scleroderma than any other connective tissue disease. As I mentioned, it tends to occur within the first 5 years, and about 40% of patients will have a restricted pattern on PFTs, and about 25% will have some degree of symptoms or abnormalities on CT at initial presentation. 90% have the presence of some degree of ILD on autopsy, though. About 35% of all deaths due to scleroderma is due to interstitial lung disease. And then later on in the course of the disease, this can be further complicated by aspiration pneumonitis. I identify the presence or concern for interstitial lung disease by screening yearly with pulmonary function tests. I do also get a baseline chest CT to see if there's any evidence of interstitial lung disease at baseline. Again, the diagnosis of ILD is based symptomatically on symptoms such as cough, fatigue, chest pain, and dyspnea, Velcro-like crackles at the base. The pulmonary function test, if there is a decline in both FEV1 and FVC, again, this prompts me to check a CT. If I hadn't before, get a first one. You may also see a reduced DLCO. And here's some findings of what I would say are classic evidence of ground glass opacities and pulmonary fibrosis in a patient with systemic sclerosis. It tends to be worse at the bases and works its way up. This is obviously fairly advanced fibrosis in a patient with systemic sclerosis. Here, as opposed to just seeing ground glass opacities, what you'll see is extensive fibrosis and what's called honeycombing. This is considered mostly end-stage pulmonary disease in scleroderma. Again, this is something that we are hoping to avoid with early intervention and immunosuppressive therapy. Again, screening, there is very little in the way of data, but many opinions. Again, for patients with scleroderma, we do get PFTs, echo, and a pro-BNP at baseline, and with symptom change. Others will do PFTs and echoes yearly. And if there's a change in an FVC or DLCO by 10% or 15% respectively, this is considered significant and may warrant further intervention. So who is most likely to progress? A study done a few years ago developed a model in which they looked at a number of different factors in patients and prospectively looked to see who progressed to develop interstitial lung disease. So they defined progression as those that had a FVC percent increase of 15% or FVC 10% increase combined with a DLCO change of 15% in 1 year. And again, these are decreases, not increases. So what they found is that the two factors that led to the greatest risk of development progression of interstitial lung disease are the presence of arthritis, as well as a decrease in the SpO2 of 94% after a 6-minute walk test. If a patient had both of these features, they had a 91% chance of progressing in terms of interstitial lung disease. Those that had a SPAR of 0 actually had a 92% chance of not progressing. So again, sometimes a 6-minute walk test can be a helpful screening procedure in patients that you feel are high risk for interstitial lung disease. Now, pulmonary artery hypertension, which again is important because it accounts for 15% of deaths among scleroderma patients. And in contrast to interstitial lung disease, this is a manifestation that can occur at any point in the disease course. It's identified in up to 20% of scleroderma patients, although again, increased risk and limited disease. Patients can have comorbid interstitial lung disease and cardiac disease. And 15% have cardiac involvement leading to systolic and diastolic dysfunction. This is something that we have begun to see a lot more of. And part of that is owing to the increased use of cardiac MRI, which can identify cardiac involvement as well as evidence of pulmonary artery hypertension. For pulmonary artery hypertension, similarly to interstitial lung disease, there are no clear data guiding the screening. However, most of us that see a number of patients will screen annually with an echo. I do this for all patients with scleroderma or mixed connective tissue disease and scleroderma features. I will get a PFT with DLCO as mentioned for the ILD. I will get TTE as well as a BMP yearly to look for signs of cardiac involvement. When do you refer to right heart cath is the question that has a lot of studies looking to answer. And a number of different criteria have come up. If we see a TR jet on the echocardiogram of 2.45 to 2 with symptoms of dyspnea or greater than 2.8, this would prompt referral for right heart catheter. If you see right atrial or ventricle enlargement, or a DLCO greater than 1.6 plus symptoms, an FVC to DLCO ratio greater than 1.6 and symptoms, or a rise in the BNP. These are all features that may lead you to refer to right heart cath. Okay, back to the patient case. So your patient calls you 3 months later. She states she saw her primary care physician for a cough and they prescribed a prednisone taper to treat bronchitis. She panicked after taking one dose when she remembered reading something about prednisone and her kidneys and stopped it after that one day. Her cough, however, persists, and she's also noted increased heartburn. She's concerned that this may be part of her disease. So scleroderma renal crisis, what is she concerned about? Again, this occurs in 10 to 20% of patients with diffuse disease, although the incidence does seem to be decreasing. 75% of it occurs within 4 years of diagnosis. And the key features that will lead you to be concerned about scleroderma renal crisis is severe hypertension, acute renal failure, and mild proteinuria. You will see a thrombotic angiopathy on path. And thus, when you look at blood work, what you may see is a hemolytic anemia as well as thrombocytopenia. And on a blood smear, you may see schistocytes. Again, these features of a microangiopathic hemolytic anemia should clue you in to the concern of scleroderma renal crisis. The treatment for scleroderma renal crisis are ACE inhibitors and to bring the blood pressure down over 72 hours. About 20 to 50% will require long-term dialysis, but I will tell you I've had patients that ultimately were able to come off of dialysis due to improvement in their kidney functions despite needing it during their period of renal crisis. I recommend patients check their blood pressures 2 to 3 times per week at home, and periodically in clinic we'll check their urine for proteinuria. In patients with an RNA polymerase III, this is probably should be emphasized as given their increased risk of renal crisis. Now to get to her question, she said, I was concerned that prednisone use may increase my risk for scleroderma renal crisis. Where does that come from? Well, when the risk factors for renal crisis have been evaluated, what's been seen is that there are a few very key factors or variables that increase your risk of renal crisis. Your skin tightness or skin thickness has a 10 times, given it, with increasing thickness is an increasing odds of developing renal crisis. The same goes with large joint contractures. However, prednisone use, and that is defined as greater than 15 milligrams per day, is associated with nearly 4 times increased odds of developing renal crisis in those that aren't taking prednisone. And again, this has been repeated in other symptoms. Now, is prednisone use simply a marker for worsening disease, and it's not due to the prednisone, i.e., is this a correlation as opposed to a causation, still has not been well established. Can ACE inhibitors prevent? There is really no data. There has been one study looking at patients who were on ACE inhibitors before renal crisis and those that were not. And interestingly, in this study, patients that were on an ACE inhibitor before renal crisis had a worse outcome, i.e. had a higher rate of those going on permanent dialysis than those that were not an ACE inhibitor. Now, does this mean we shouldn't use ACE inhibitors in patients with scleroderma that don't have renal crisis? No, I think this was a small study and not necessarily definitive in that takeaway. However, I don't use ACE inhibitors the same way we would use them in, say, patients with diabetes to prevent renal involvement. Now, this is a slide about the GI manifestations, and it's really there to emphasize the fact that while we associate scleroderma with esophageal involvement, and truly about 80 to 90% of them patients will have some form of reflux or dysmotility of the esophagus and stomach. This picture is really meant to emphasize just how extensive the GI involvement can be. It starts at the mouth, and that actually includes having a small oral aperture due to skin involvement. They may have Sicca or Sjogren's syndrome or dental disease. And if food can't easily get from the mouth to the esophagus, you're already going to have problems swallowing if there's involvement of the esophagus later on. It can involve the stomach and lead to gastroparesis. It can lead to gastric antral vascular ectasia, as well as ulcers. It can involve the liver, and up to 2.5 to 5% may develop primary biliary cirrhosis, particularly patients with limited disease. I do get ALK phosphors on them periodically to evaluate for the presence of early primary cirrhosis or cholangitis. Patients can have involvement of the small intestine, leading to small intestinal bacterial overgrowth or pseudo-obstruction. They can have involvement of the large intestine, leading to pseudo-obstruction. They can have involvement of the rectum and anus, leading to fecal incontinence. And about 10% of patients will have some degree of fecal incontinence. A much smaller number of patients will tell you about it. So again, in any of my patients that have any GI involvement, I'll ask them, do you have fecal incontinence? And they will often say yes, and we'll talk about ways that we can help them with that symptom. But oftentimes, if you don't ask, they won't tell you that. So how do we evaluate for GI disease? I think the first step in most patients is an endoscopy. Now, again, if they have symptoms of reflux, of difficulty swallowing, this can help not tell you necessarily if it's scleroderma, but tell you if it's something else. Could they have candida and an infectious esophagitis? Could they have pill-induced esophagitis? Could they have severe GERD? Could they have Barrett's esophagus, which is seen in up to 10% of patients with systemic sclerosis? Do they have gastric antral vascular ectasia, also known as watermelon stomach? Now, this is seen in the bottom right-hand corner, and you can probably tell where it gets its name, watermelon stomach, due to the pattern of involvement. This is important in that this can lead to iron deficiency anemia due to small and subtle leakage of blood, and is actually treatable. So it's important to know if this is affecting their disease. If you see a patient with iron deficiency anemia, it's important to get an endoscopy to see if this can be evaluated and treated. Patients may also have celiac disease contributing to symptoms of diarrhea, bloating, and endoscopy may be a helpful way to diagnose that. If there is a significant stricture, dilation can be helpful. However, I would say one consideration is that in patients with scleroderma, there is a slightly higher risk of perforation with dilation that we may not see in patients without scleroderma. The only time I see dilation as a really helpful treatment is if the reflux is so bad that it leads to inflammation and a stricture, and then in those patients, dilation can be helpful. Otherwise, the problem in scleroderma is the esophagus becomes more of a pipe, in which case it becomes firm and rigid, and dilation isn't all that helpful in improving movement through the esophagus. Esophageal manometry is another often used imaging modality and testing modality to look for signs of dysmotility in patients with scleroderma. And the pictures here actually tell a whole lot, and they're really interesting to see. So again, if you have a patient undergo a manometry, I would encourage you to look at it yourself so you can see what the gastroenterologist is looking at. In the patient with the normal manometry, what you'll see is over time, and that's on the x-axis, there's increase in pressure as a food bolus moves through the esophagus, and that's a sign of peristalsis. Increased pressure moves food through the esophagus over time. In patients with scleroderma, they will have a very classic manometry appearance in that there is no increase in pressure as food moves through the esophagus. There's hypotension and aperistalsis. And this finding on manometry is important for differentiating achalasia, which would have the opposite appearance, meaning increased pressure at the bottom of the esophagus, and scleroderma. So back to your patient. So she had an endoscopy. It showed significant reflux. And after 2 years, she's been on a proton pump inhibitor, and this has been helpful. She missed a few years of follow-up due to COVID, and that's been tough on her, but she is now ready to get back and get some help for her disease. And the reason for that is because over the last 6 months, she's had progression of her skin disease. It feels tighter. She's had a daily dry cough that didn't improve with the proton pump inhibitor, and progressive shortness of breath. She's measured her oxygen levels, and she's had oxygen desaturations. She feels that in addition, her Raynaud's is worse, and she's developing finger ulcers. You do some workup at that time. Her workup demonstrates worsening PFTs and evidence for interstitial lung disease on CT scan. She states at this point, given how she feels, she is ready to consider immunosuppression or any other treatment. So that brings us to, how do we treat this disease? I use this framework oftentimes with my fellows and my patients to really describe how we take care of this disease. And I split the treatment of scleroderma into 3 main buckets. The inflammatory aspects of the skin, meaning the lung, the skin, the myocardium of the heart specifically, although this also includes joints if they develop arthritis, and muscle if they develop comorbid myositis. For patients with the inflammatory, this is where we focus a lot of our immunosuppression. The 3 primary drugs, methotrexate, CellCept, and cyclophosphamide, are probably our go-to drugs in 80 to 90% of patients, with mycophenolate mofetil being the primary drug used, particularly for patients with lung disease. For patients with advanced refractory disease or they're intolerant of these medications, we do have a number of other therapies, including tocilizumab and rituximab. IVIG has been used with increased use. Prednisone, and again, I put a big question mark there, given the potential risk for renal crisis, but prednisone may also have a role. I've had patients who were given prednisone that didn't develop renal crisis and felt that it was actually quite helpful for them early in the course of their disease. So perhaps there is a window where prednisone may be helpful. In the last few years, there's also been some increased interest in the use of antifibrotics, including the drug nintedanib, for treatment particularly of lung disease. For patients with vascular disease, such as Raynaud's or pulmonary artery hypertension, we focus our treatment on vasodilators. And the treatments of choice initially are calcium channel blockers. However, we frequently also use PDE5 inhibitors, such as sildenafil or tadalafil for severe Raynaud's. Once a patient develops pulmonary artery hypertension or very advanced Raynaud's with ulcers, then we start thinking about advanced therapies, including endothelin receptor antagonists, prostacyclin analogs, drugs like selexipag and riociguat, which are used primarily for pulmonary artery hypertension. And this is where collaboration with our pulmonary hypertension doctors is incredibly crucial for use of these medications, and I work very closely with them. For GI disease, on the other hand, this is almost exclusively symptomatic management. The drugs we use for inflammatory disease oftentimes will not help the GI disease and frankly frequently make things worse. The most common side effect of some of those medications are increased diarrhea, cramping, and abdominal pain. For patients with reflux and heartburn, I primarily use PPIs. For those with dysmotility, there are a number of agents that have been used as promotility agents, such as metoclopramide, erythromycin, domperidone, which is primarily available through Canada, and prucalopride, which is newly available in the United States. Antibiotics, particularly if they have small intestinal bacterial overgrowth, the best studied one being rifaximin, although other antibiotics have been used. And for patients that have constipation related to large bowel involvement, laxatives can be very helpful. But this really requires individualized treatment to help with their GI disease. So in thinking about treatment, we've often focused on lung disease, and part of the reason is its contribution to mortality. The other reason is that we have fairly specific outcome measures that we can look at, that whether that's imaging such as a high-resolution CT or pulmonary function test. These are things that we can relatively easily measure and say, is there an improvement or not? The first major clinical trial for scleroderma, particularly with lung disease, is called the Scleroderma lung disease or study that was published in 2006, which looked at cyclophosphamide compared to placebo. These are patients with active alveolitis on high-res CT or bronch. They had relatively early disease within the first 7 years, and they had an FVC that identified a restrictive pattern. They also had to have dyspnea. So again, this was oral cyclophosphamide while we primarily use IV. What the outcome showed was an improvement compared to placebo in those in the cyclophosphamide group. And again, this was one of the first studies that really showed in a randomized prospective way that a drug may have an impact on lung disease and scleroderma. As you can see, in patients in the cyclophosphamide group, they had a much smaller, or at least a statistically significantly smaller reduction in FVC than those on placebo. That being said, it was a fairly modest difference between the two. Statistically significant, yes, but a fairly modest clinical difference. What you can also see is that there was a relatively more significant difference in the reduction of skin thickness in patients on cyclophosphamide compared to placebo. So certainly two main clinical features that were improved with cyclophosphamide compared to placebo, leading to the first really major drug that we had in our armamentarium to treat scleroderma. Of course, there was an increase in patients on cyclophosphamide in terms of leukopenia, neutropenia, and pneumonia. What's interesting, however, is that in patients that were treated with cyclophosphamide, if we followed the study patients out to 2 years, you can certainly see a difference early on in the cyclophosphamide group and actually improvement over time. However, at 24 months, both the placebo and the cyclophosphamide group were pretty much back to where they were originally without any significant difference. Again, there's a need for treatments with less toxicity and greater efficacy over time than cyclophosphamide. This led to other studies and other drugs, including mycophenolate mofetil, which is the scleroderma lung study too. And this study compared CellCept to cyclophosphamide, again, oral cyclophosphamide, looking at the change in FVC. What they found is that there was no difference between cyclophosphamide and CellCept in their primary or secondary endpoints. But what they did find was that mycophenolate mofetil was better tolerated. Because of less toxicity and greater tolerance of the mycophenolate mofetil, it has largely replaced cyclophosphamide as our drug of choice for induction therapy in patients with scleroderma lung disease. Rituximab is not FDA approved for treatment of scleroderma. However, there are a number of case series that have shown improvement in both skin disease as well as lung function in patients given rituximab. Currently, we are using rituximab, again, in patients that are intolerant to mycophenolate mofetil or are refractory to that. Tocilizumab, however, is the newest FDA approved drug for the treatment of systemic sclerosis. And again, the approval of this drug was based on the phase 3 trial, the FOCUS trial, which involved 210 patients with a disease duration of less than 5 years. These patients had significant skin involvement and active diffuse disease. 65% of the patients enrolled in this trial did have interstitial lung disease, and this was a placebo-controlled trial. What you can see here is that patients in the tocilizumab trial, tocilizumab group, had an improvement in their baseline FVC compared to those with placebo, and that's seen on the right. What we didn't see was a significant improvement in skin disease. However, there was a trend towards improvement in the tocilizumab group. On the basis of this drug has now been approved for the treatment of patients with scleroderma lung disease. Finally, nintedanib, which is a potent inhibitor of growth factor, specifically TGF-beta, was studied in a very large clinical trial, one of the largest clinical trials to date in scleroderma, where patients were randomized to the active study drug nintedanib versus placebo, although patients in the placebo group, importantly, could still remain on their background CellCept or methotrexate if they were on this. Again, the primary endpoint was the annual rate of decline in FVC, and you can see here very clearly that patients in the nintedanib group had a slower rate of decline than patients on the placebo. Again, this has led to FDA approval of nintedanib for the treatment of scleroderma lung disease. Similarly, tocilizumab nintedanib was not shown to lead to significant improvement in skin disease. And again, this was a post-hoc study looking at the improvement in FVC in patients on nintedanib versus placebo. Again, looking at these trends and differences in the study group versus placebo. The last treatment for interstitial lung disease that I'll talk about very briefly is stem cell transplant. This is really a treatment that we have used for the most aggressive disease patients and the most rapidly progressive patients. Over 700 of these have performed. We've done about 30 here at Duke. The majority of them are autologous, meaning giving patients their own cells back after myeloablation. And the idea is that we profoundly reduce the autoaggressive immune cells and replace with tolerant stem cells. This is a review we published here a couple years ago, comparing the three main trials, the ASSIST, ASTIS, and SCOT trial, and their outcomes in showing that in select groups of patients with aggressive disease, stem cell transplant, and in all of these, autologous stem cell transplant led to improved outcomes overall compared to treatment with cyclophosphamide. Now, we have not done the study comparing this to the mycophenolate mofetil, and those studies are ongoing. In the last few minutes, I'm going to point you towards an article that was published a few years ago in Arthritis and Rheumatism. And this article polled 160 specialists in scleroderma and basically came up with a treatment algorithm based on the agreement between the various providers in how they would treat patients with various manifestations of disease. And I encourage you to take a look at the study and see, and using this as almost a treatment guideline and algorithm, although again, treatment has to be individualized to the particular patient. So for most patients with minimal or moderate skin disease, there's pretty even use of both methotrexate and CellCept, and certainly switching to CellCept without improvement in methotrexate. For patients with more advanced disease, most would start with mycophenolate mofetil before methotrexate, but then aggressively trying other treatments like cyclophosphamide and stem cell transplant. And mind you, this study was done before the approval of tocilizumab. Similarly, for lung disease, as I mentioned, for induction therapy, most would use CellCept as frontline, and switching to second line IV cyclophosphamide if no improvement. Rituximab and other trials can be considered if no improvement. For Raynaud's, again, the vast majority would start with a calcium channel blocker, although those with severe disease, they'll be likely to add a PDE5 inhibitor or a prostanoid fairly quickly due to the severity of disease. For fifth line, you'll see here, and these are things that we do use, Botox injections or digital sympathectomy can be used, again, in refractory cases. For gastrointestinal disease, again, it really depends on what part of the GI tract is involved. There's high agreement with using a PPI as first line, and then with dysmotility or worsening symptoms, adding a promotility agent. If there's small bowel involvement and findings of bacterial overgrowth, using an antibiotic is a very easy answer. Those that have GAVE, we use argon laser treatments with the assistance of our gastrointestinal colleagues. For constipation, laxatives for incontinence, there unfortunately is not a lot of great options. I do use fiber as a bulking agent, but biofeedback can be helpful for some patients. And again, with chronic severe malnutrition, this is a talk unto itself, but these patients have a significantly poor prognosis. We do start with oral nutrition, but quickly move to TPN or a GJ tube for more severe malnutrition. That being said, patients that go on TPN for malnutrition will often need to develop, will often have a poor motility with over a 50% 3-year mortality. So I'm going to summarize, I give a few more minutes, that systemic sclerosis is a rare heterogeneous disease. Again, key takeaway points: 95% will present with Raynaud's disease, and over 80% will have GI disease. Less than 50% will develop ILD or PH, but this is a major contributor to mortality. I screen yearly with at least PFTs and an echocardiogram, and I think that this is the standard of care for identifying interstitial lung disease. For patients with changes in their PFTs or echo or symptoms, we then do more advanced studies such as CT scans or a right heart cath. For patients with progressive lung or skin disease, immunosuppression is indicated, with mycophenolate mofetil or CellCept being the most common initial drug. Vascular manifestations are treated with vasodilators, although non-pharmacologic treatments are often needed. And I will add, I often send patients to the website www.raynauds.org. I find this to be an incredibly helpful site. They even have products that they partner with that can be helpful as non-pharmacologic treatment for Raynaud's. GI disease is treated symptomatically, and notably, the medications we use to treat other aspects of the disease may make the GI disease worse. So if their GI disease is getting worse, you may have to consider it's the other medication that's doing it. And finally, there's a lot more work left to do to help our patients with scleroderma. And with that, any questions? And certainly for those of you listening at home, you can send me an email if you have any questions, and in particular, any patients that you are considering for stem cell transplant, as I'm happy to advise in that scenario.
Thank you so much, Dr. Shah, for that wonderful overview. Have a question regarding some of the treatment of the skin disease for scleroderma. So scleroderma patients will often present at very different stages to our rheumatology clinic and scleroderma clinic. Some onset new, some have had disease for several years, some diffuse. When in the disease course is immunosuppression most helpful for treatment of the skin disease? How long do you usually give it to work, and at what point do you consider tapering?
Yeah, great question. This comes up probably every day in clinic that I see patients. I usually start with any, if they have very mild skin involvement of the hands, I may start with occupational therapy and following them very closely. But anything that leads to any significant dysfunction, grip strength, holding things, or anything more than that, I will start immunosuppression fairly early on. And I've seen the best outcomes with that. Again, if it's mild, I'll use methotrexate, but I would say far more commonly, I'll use mycophenolate mofetil if they can tolerate it. I generally treat skin disease for 5 to 6 years, and then I'll start tapering medications. If a patient comes to me with 15 years of disease, unless they feel that their skin disease has worsened, I don't start any therapy at that point. And I really focus on things like occupational therapy to help with contractures or anything that they have. What patients will often tell me is that, despite the fact that they have contractures, after that 6 or 7 year point, they'll say, well, while my contractures are still here, my skin has loosened up a little bit. And again, I don't find that immunosuppression at that point really leads to any meaningful improvement.
Great, thank you. You mentioned or you talked majorly about the sort of limited and diffuse subtypes of scleroderma. There's another small section, about that 5% of cine scleroderma. How do you go about recognizing those in your clinic, especially when they're not having any sort of the cutaneous manifestations? I guess, how are they presenting?
Yeah, I think, when you go back to that 2013 framework, it really allows for patients to meet the criteria definition of limited scleroderma without any skin involvement. So I really put those patients, and I agree, that number sounds about right, about 5% of patients, alongside my limited systemic sclerosis patients. I can tell you I have a number of patients that really have no skin involvement whatsoever, but they have terrible Raynaud's, or they have terrible GI disease. So again, unless they have skin disease or lung disease, or myositis, I don't put them on immunosuppression, and I focus my treatment on the symptoms that they have most, whether that be vascular or gastrointestinal. But I treat them and I screen for them the same way I screen with my limited patients with PFTs and an echo to look for pulmonary hypertension and ILD.
Great. One other patient that often kind of shows up in our scleroderma clinic is that patient with localized scleroderma. What is localized scleroderma and how does it differ from systemic sclerosis? And what can we tell these patients?
Yeah, great question. I have them too. I have a great fibrosing skin disease clinic from my dermatologist. So in one hand, I talk to them, and the other hand, I make a referral to them. But so localized, linear, morphia, peri-Romberg, these are all forms of fibrosing skin disease that's limited to the skin. That being said, you can have diffuse skin involvement without any internal organ involvement. Some of these patients may have arthritic complaints and pain related to their scleroderma, their morphia or localized scleroderma, but they tend not to develop any internal organ involvement. They're more frequently ANA negative, is what my observation has been. So these patients, like as I mentioned, I work closely with my dermatology colleagues for really kind of limited, that's not the best word to use, but for not significant skin involvement, we'll use topical therapies, topical steroids, tacrolimus, calcipotriene, sometimes intralesional steroids. However, if they are refractory to that, or they have a greater percentage of skin involvement, we do use methotrexate and mycophenolate mofetil, similarly to the way we use them for advanced skin disease in systemic sclerosis.
Thank you. We have one last question that just came through. So if the inflammatory arthritis and scleroderma, what specific agents do you choose? Is there one that you prefer over others, or do you jump directly to tocilizumab?
Yeah, great question. I can give you my personal experience. I didn't put it up there, but in that algorithm paper, they do actually specifically talk about inflammatory arthritis. So again, I encourage you to use that. If inflammatory arthritis is sort of the major manifestation without a lot of other skin involvement, I'll use methotrexate. I find that mycophenolate doesn't help as much with the inflammatory arthritis. I'll use hydroxychloroquine again if it's sort of more mild, similar to the way I approach rheumatoid arthritis. If there's more significant skin or lung disease, particularly with lung disease, I don't use as much methotrexate. I may go to the rituximab or tocilizumab, particularly if they're seropositive. Some of that also is an insurance thing, but then I find that I'm getting maybe double coverage for their inflammatory arthritis and their scleroderma lung disease.
Great. Well, thank you so much, Dr. Shah. I think at this time we're ready for that speaker review to come up, and the content, if you can just answer those couple of questions, we really appreciate that in refining our talks. All right. And now I will hand it over to Dr. Andrew Jones, who will be introducing our next speaker, who will be covering the myopathies.
Hello, everyone. Thank you for joining us. I have the pleasure of introducing Dr. Iazsmin Ventura today, who's joining us from the University of Chicago. She is a general rheumatologist with main interests in idiopathic inflammatory myopathies and autoimmune-related lung disease. She is a member of the multidisciplinary interstitial lung disease program and the director of the myositis program at the University of Chicago. She closely collaborates with international experts to achieve state-of-the-art medical care in these complex diseases and frequently engages in patient education projects. Dr. Ventura has the pleasure to work with medical students, residents, and fellows regularly to teach them about these diseases and share her expertise. So thank you, Dr. Ventura. I'll hand it over to you.
Hello, everyone. Well, first of all, congratulations for becoming a rheumatology fellow. Is a wonder specialty, and I welcome you to this very collaborative, very unified community of physicians. So welcome. Let me share my screen. 1 second. Can you all see my screen? Okay. All right, so let's get started. It will be hard to follow Dr. Shah in his wonderful lecture. There's a lot to be learned still about systemic sclerosis, and is even this lack of knowledge and so much is still to be done in inflammatory myopathies is also true, and maybe even more important in inflammatory myopathies. The scleroderma people are ahead of us than the myositis. So quick overview, we are going to talk mostly about the clinical manifestations of inflammatory myopathies. We'll discuss the most recent developments, particularly with respect to classification criteria in myositis-specific antibodies. We'll do a quick overview on muscle histology and a quick review as well on some of the algorithms for the treatment of these diseases. So most of you, that's at least what happened to me, may have learned that inflammatory myopathies are divided in 3 big groups: dermatomyositis, polymyositis, and inclusion body myositis. And the truth is that things are way more complex than the initial division. So nowadays we know about overlapping myositis syndromes, antisynthetase syndrome, immune-mediated necrotizing myopathies. And again, this classification criteria of inflammatory myopathies got way more complex. As of now, these diseases are under the umbrella of, again, inflammatory myopathies, and they are characterized by muscle weakness, low muscular endurance, and which are the hallmark of these diseases, but also extramuscular manifestations remind us of the systemic inflammatory nature of these diseases. Epidemiology, so who gets inflammatory myopathies? This is really a difficult question. Population-based studies do not provide a good framework on how to understand the incidence and prevalence in the general population. Clinical cohorts in university hospitals are complicated because they probably underestimate the true numbers, given that we receive referrals of patients who are most complex. Registry-based studies may overestimate, given the misclassification by physicians not specialized in inflammatory myopathies. And we unfortunately cannot use ICD-10 to do studies on incidence and prevalence because the ICD-10 is outdated and unfortunately does not encompass these new subtypes of inflammatory myopathies that I alluded to. So with that in mind, the incidence is up to 660 per 1 million person years, increases with age, peaking around 50 years old. The prevalence is everywhere between 3 to 34 individuals per 100,000 in the population. And be mindful that these studies were done in North America, some Asian countries, usually China and Japan, and also European countries. So we have underrepresentation of South America and Africa here. There is a north to south gradient. Usually the dermatomyositis is more frequent around the equator or closer to the equator the country is. And most patients affected, as usually it is the case in systemic rheumatic diseases, are women. However, this is the first exception that we're going to talk about in inclusion body myositis, which affects mostly men compared to women. Let's talk about some of the risk factors that we have identified in the development of inflammatory myopathies. So this is a overall table bringing the most important studies. Usually, again, there's always that concern that infections may trigger autoimmune diseases, and there are some registry studies mostly coming from the Swedish group saying that infections, any of them, seem to be associated with the development of these diseases. However, upper respiratory infection and parvovirus may not show the same kind of trend. And when it comes to non-infectious agents, it seems that very extraneous physical exertion, bovine collagen implants, skin implants, and in particularly smoking with anti-Joe antibodies are important risk factors of inflammatory myopathies. I want to emphasize here, because you are going to be, if you have not been asked about this, you will soon. Vaccines do not seem to cause inflammatory myopathies, and the lack of association between vaccines and inflammatory myopathies continues even with the new COVID-19 vaccines, okay? So vaccines seem to be safe when it comes to inflammatory myopathies. Right, there are some genetic alleles that have been associated, mutations that have been associated with inflammatory myopathies. And again, the important association with the HLA region reminds us that these are autoimmune diseases, and the immune regulation for which HLA is so important it just reflects the fact that we're dealing with an autoimmune disease. I want to point out again that most of these studies, if not all of them, are represented by patients with European ancestry, and we don't have minority, ethnic, and racial groups as part of these genetic studies. So this is just a quick figure illustrating how complex the evaluation of environmental risk factors is for the development of inflammatory myopathies. Is probably a combination of environment, genetic factors, the lack of protective mechanisms that lead to the development of different phenotypes of inflammatory myopathies. All right, let's jump into the clinical manifestations. Okay, so muscle weakness, again, is the hallmark of inflammatory myopathies. And I want to dedicate some time talking about muscle weakness. Most patients with inflammatory myopathies, they have weakness in the clavicle and hip girdle muscles. So we're talking mostly about shoulders, hip muscles, upper thighs, and the neck can also be affected, okay? Usually the neck flexors, although extensors are commonly affected as well. The disease can present in acute, subacute, and clinical fashion, depending on what kind of subtype you're talking about and how aggressive the disease is. The disease is proximal, is usually symmetric. And I want to spend some time here to help guide how to better ask our patients about proximal muscle weakness. Just asking them if they feel weak or not is not really the right way to evaluate weakness, especially because history taking is quite important in this patient population. So you're going to ask about difficulties rising from a low chair or the toilet seat, or even rising from the floor, difficulties going up the stairs without using rail for support, any problems washing the hair, or reaching up to a high cabinet in the kitchen because of weakness in the arms. And is there any problems keeping the head straight up in a daily basis as well? Again, this is inclusion body myositis being the odd child in the family. It's always, inclusion body myositis is part of several exceptions that we're going to be talking about for the rest of our presentation. The muscle involvement in inclusion body myositis is quite different from the ones in the other myopathies. First of all, these patients have very indolent chronic presentations. I'm talking about 5 to 10 years to the point of beginning of symptoms to the diagnosis. So the symptoms really progress in a slow manner. And the patients usually have not only proximal muscle weakness, but they commonly have distal muscle weakness. And this is particularly true for the wrist and finger flexors. So patients have a hard time making a grip, foot dorsiflexion, and knee extensors. So these are some pictures of patients with inclusion body myositis. On your left upper side, you have someone trying to make a grip with their hands, and you can see that this person cannot properly bend the DIPs and PIPs. That's because she has an early involvement of the finger flexors that I mentioned. Here on the right upper side, you can see someone with more advanced disease. And in this patient, you can already see the muscle atrophy of the wrists of the forearms, and this patient is unable to bend beyond the MCPs. Here you can see in image letter C, the muscle atrophy, how pronounced it is in the forearms. And then moving on to the lower extremities in figure D, the muscle atrophy in the quads. Here, a quick imaging figure from an MRI with normal tissue. You can see this homogeneous, darker green tissue reflecting normal muscle. And down here in patients with IPM, basically fat replacement of the normal muscle tissue. Okay, so this is a very nice figure that puts together the muscle involvement in specific inflammatory myopathies. So in blue, you have inclusion body myositis. In red, you have patients with the other inflammatory myopathies. And in yellow, the muscles are affected by both. So you can see how IBM, inclusion body myositis, has more distal involvement. The extensors, the knee extensors are quite important too, whereas patients with other inflammatory myopathies has more proximal involvement, affecting particularly the shoulders, the hip flexors, and the hip abductors and extensors. Okay, so patients with inflammatory myopathies, because the skeletal muscle is affected, I want to remind you that the upper third or the upper half of the esophagus is also skeletal with striated muscle, and therefore can get very weak when patients are, when the disease is active. So these patients have a hard time swallowing. Some of these patients may even become hoarse, and you need to ask them if they are having a cough after swallowing, if they need to wash food down or swallow many times to be able to move the bolus of food down, or if they have experienced more recent choking and nasal regurgitation with liquids. Myalgia is not frequent in inflammatory myopathies, but it can happen, particularly in patients who have a more acute, severe presentation. Respiratory muscle weakness is usually a reflection of patients who have a more severe, long-standing disease. And sometimes patients will now tell you that they have weakness in the respiratory muscles, and the way to find out is by identifying nocturnal hyperventilation. As expected, again, if there is muscle inflammation and muscle breakdown, I would expect the CK, aldolase, LDH, AST, and sometimes ALT to be elevated in patients who are having active disease. Rarely, aldolase can be elevated with normal CK, and CK is a very sensitive test and can be used for disease monitoring over time. All right, let's talk about tests to evaluate patients with muscle weakness. The MRI, it is a very important tool. Okay, so I just want to show you here the highlights. On the left upper corner, you have the T1 sequence, and this sequence is particularly important to show you chronic degenerative changes. The fat tissue replacement of muscle tissue is what we see in T1. So this area here that is more bright, that is wider, is the one that is reflecting more fat where it was supposed to be muscle. And here, turning to the SIR-T2 images, we identify areas of edema and inflammation, and you can see as well that it looks brighter on T2 sequences as well. So in this particular patient, this patient has active disease seen by edema in SIR-T2, but also already signs of degeneration, fatty atrophy here in T1 as well. These are the images here, a quantitative analysis that can show you better the edema and fatty atrophy, but they're not widely available in most centers. Gadolinium contrast is not necessary all the time, and you can review with your radiology team what are the sequences that are available for evaluation of patients with muscle inflammation. When it comes to electrodiagnostic testing, they can be quite helpful too. So remember that electrodiagnostic testing is separated in two specific branches, I would say, or phases. First of all, most neurologists or other specialists provide this test. They perform a nerve conductive study to identify if there is any abnormality in the ways the nerves are functioning. As expected, the sensory nerve conductive study should be normal, as it is the case with motor nerve conductive studies, unless the disease is very severe and also involves more distal muscles. Sometimes that can be abnormal. But the money is really in the EMG. The EMG is helpful in confirming a myopathy, narrowing the differential by identifying which muscles are affected, and also identifying a biopsy site. It is important to mention that even for patients who have a muscle manual test normal in your physical exam, if these patients can be identified as having muscle weakness by EMG. So it's a very sensitive test in the right hands. For patients who have disease activity, ongoing inflammation in the muscles, we see signs of muscle membrane irritability, which are fibrillations, positive sharp waves, and myotonic discharges. For patients who also already have signs of muscle damage, either because the disease is long-standing or very severe, we see a decrease in the motor unit action potential. So these potentials are small, short, polyphasic, and they recruit early. So the muscle fibers, when they degenerate over time, others in the neighborhood are recruited to be able to contract the muscle. Extramuscular manifestations. The presence or the absence of extramuscular manifestations is extremely helpful and crucial for establishing the diagnosis of inflammatory myopathies and also determining what kind of subtype of inflammatory myopathies we're talking about. And I want to remind you, sometimes patients only have extramuscular manifestations and they really have muscle weakness, even though they are categorized as a myopathy. All right, this is a figure that kind of summarizes the main organs that are affected. Again, we talked about muscle weakness, but a lot of these patients have arthritis as well, Raynaud's phenomenon, lung disease, myocarditis, dysphagia, oropharyngeal dysphagia like we discussed, but also lower esophageal dysphagia, very similar to what we see in patients with scleroderma, and also the characteristic dermatomyositis rash that we're going to talk about in a little bit. All right, let's talk about myocarditis first. Myocarditis is uncommon. Most patients have subclinical disease and therefore have under-recognized myocarditis. And the patients who are usually affected are the ones who have scleroderma myositis overlap, or the ones who have a specific antibody called SRP. The cardiac MRI can be very helpful. And I want to say a word here about different kind of troponins you may have in the hospital. Cardiac troponin 1 is a wonderful, very sensitive and specific test for myocardial involvement. Whereas troponin T, which is available in many hospitals, definitely in mine, can be elevated. It's not as specific as cardiologists say. It can be elevated in patients who have skeletal muscle disease only. So be mindful what kind of troponin patients are getting ordered, because they can give you a clue which muscles are affected. Arthritis can resemble very much what we see in rheumatoid arthritis. And I cannot tell you how many patients have come to me saying they have been diagnosed with seronegative rheumatoid arthritis in the past, when they have actually a antisynthetase syndrome or dermatomyositis with a pronounced inflammatory arthritis. And the symptoms are very similar, with hands and wrists being affected. Most cases are non-erosive, although I definitely have seen in my practice erosive disease. ILD. Okay, that's where the situation gets a little more complicated. ILD is the main reason for mortality in patients with inflammatory myopathies. And it is strongly associated with a group of diseases, a subtype of inflammatory myopathies called antisynthetase syndromes, and is also very important in patients who have MDA5 dermatomyositis. The disease can be quite rapid progressive, and sometimes the diagnosis of a dermatomyositis is established in patients already in the ICU receiving ECMO. Other than this synthetase syndrome and MDA5, patients who have other types of dermatomyositis, overlap myositis syndromes, particularly the ones with scleroderma overlap, and polymyositis can also be affected. And it can be, and the prevalence of this manifestation can be very high, depending again, which group you're including in your analysis. The most common patterns are non-specific interstitial pneumonia here in your left corner. You can see ground glass opacifications, mostly in the periphery and the lower lobes. And this fine line of pleural sparing here, which is characteristic in SIP. And here on the other side, you have organizing pneumonia or OP with this bronchovascular dense opacifications, very commonly associated with airborne programs as well. The combination of those can also happen, and other patterns can also be present in patients who have ILD and myositis, although these are the most common. As expected, the pulmonary functional test will show you restrictive patterns with decreased LCO. And although there are no guidelines on how to screen these patients, I definitely recommend patients should be screened with CT scans. High-resolution CT scans to be more precise, very fine cuts, 1 millimeter cuts, and also PFTs at baseline. And whenever if patients don't have any signs of lung involvement, I may recommend PFTs on a yearly basis, very similar to what the scleroderma experts do as well. Cancer association, big thing. Our patients with inflammatory myopathies are more likely than the general population to be diagnosed with cancers, particularly in the year prior and year following their diagnosis, although the risk may linger for a while. We don't have guidelines on when and how to screen. I am very aggressive at screening these patients on diagnosis at baseline with CT scan, abdomen, and pelvis. This is a good moment to get in your high-resolution CT scan as well. Upper and lower endoscopies, again, mammograms, transvaginal ultrasounds, pap smears, testicular ultrasounds, and some authors may also argue in favor of PET scans, which are not always available and very expensive. So my recommendation is to be very mindful of cancer screening right away, particularly for patients who have the dermatomyositis and are positive for TIF1 and an XP2. Those are the patients who have a greater risk for cancer. Right, let's talk about skin. So heliotrope rash, this purpuric edematous, erythematous inflammation associated with swelling affecting the lid, sometimes just the upper lid, sometimes both, is usually symmetric, although again can be asymmetric in presentation. Very typical of dermatomyositis, considered to be pathognomonic, although other diseases can present similarly. Goldschorn's papules, this papules of erythematous, again with that purpuric hue, associated sometimes with desquamation and hyperkeratosis, usually affecting the knuckles, so the MCPs, PIPs, and TIPs of the hands, very classic of dermatomyositis. Just want to point out an interesting finding here. Some patients may develop this almost what we feel a inverted pattern of Goldschorn's with erythema in between the knuckles, in between the joints, in the interphalangeal areas, and we call them inverted Goldschorn's papules. And these are actually a cutaneous finding of systemic lupus erythematous, fun fact. These are Goldschorn's sign with the redness, with the erythema, again, the purpuric color, sometimes with desquamation that can even resemble psoriasis affecting the extensor surfaces of the knees and the elbows. Goldschorn sign can also happen in the lateral sides of the hips. And I want to dedicate some time here talking about the capillary changes that Dr. Shah mentioned during his presentation. So sometimes you don't even need to have an ophthalmoscope or dermatoscope to be able to identify them. They are easily available. Differently from scleroderma, which the changes can be a little more subtle. That's not the case with dermatomyositis. And some patients will not have any other clinical manifestations, only the erythema in the periungular area. I want to mention that ragged cuticles, irregular cuticles, thickened and dry cuticles may be also the only clinical manifestation these patients may have in terms of skin involvement. This is a V sign, very photosensitive erythema around the neck and upper chest. Shawl sign, again, the same kind of presentation, but affecting the upper shoulders and a posterior neck. And this sparing, this rash can extend all over the back, although in some patients can spare the mid-back, which is very interesting finding of dermatomyositis. Poikiloderma is not specific for dermatomyositis by no means. Even patients who have exposed themselves to sunlight over the course of several decades can develop poikiloderma. This is hypo and hyperpigmentation of the skin associated with skin thinning, skin atrophy, and telangiectasias, and they can be the presenting feature of dermatomyositis or the result after that very photosensitive rash resolves. Calcinosis cutis is very common in patients who have NXP2 kind of dermatomyositis. These patients have this dystrophic calcific depositions underneath the skin, muscles, tendons, and they can extrude the skin, they can become infected and extremely painful. Also more common in patients who have scleroderma overlap. And I want to remind you that a lot of these rashes that we talk about are usually familiar to physicians in patients who have white skin, but the rashes may have a very different kind of presentation in patients who have darkened skin colors, with hypo and hyperpigmentation being sometimes the main features. Erythema may not be as easily appreciable. And unfortunately, this lack of familiarity from physicians and how these cutaneous presentations behave in darkened skin patients may lead to the disease delay diagnosis by many years, which is very sad. All right, let's talk about subtypes. Well, we have been talking about dermatomyositis for some time already. Given the rashes, let's continue with that. So patients with dermatomyositis can usually have, again, muscle and skin involvement. Although some patients may only have skin disease and no muscle disease, we call them amyopathic or hypomyopathic dermatomyositis, depending on the evidence of elevated CKs or not in the blood test. And some patients may have actually clinical presentation with muscle involvement without the skin, and you do a muscle biopsy, and the muscle biopsy shows very similar features of dermatomyositis, but again, the skin may not be involved, and those patients are called dermatomyositis sine dermatitis. So even though dermatomyositis is, again, the involvement of skin and muscle, it can also happen with muscle disease only and skin disease only. Dermatomyositis patients usually have what we call myositis-specific antibodies. And the myositis-specific antibodies, these are the most common ones, these 5 antibodies that I have reviewed here. We're going to talk a little bit more in a few slides. And some patients may also have an antibody-negative dermatomyositis. The most important thing I want you to get from this talk is that antibodies strongly predict clinical phenotypes. Depending on the antibody you have, your dermatomyositis presentation may be different. All right, let's start with MI2 and dermatomyositis. These patients are your classic dermatomyositis, the one you read about in medical school and internal medicine, the classic rash, muscle involvement. And these patients usually have a better prognosis. They respond to treatment, and they don't have as much lung disease. TIF1 dermatomyositis is the one that we usually associated with cancer that I mentioned to you a few slides back. These patients usually have the classic dermatomyositis rash as well, and they can have myositis, but it's not as important. The MDA5 dermatomyositis is the one for which lung disease is our main problem. We need to monitor these patients, and sometimes lung disease is their presenting manifestation. These patients can also have skin involvement, and Raynaud's and arthritis, inflammatory arthritis, are important features as well. This is a very typical presentation of MDA5 positive dermatomyositis that is very unique of this antibody. It is ulcerations in the hands, sometimes in the hard palate as well, not only affect the dorsum, but the palms too, and it's very typical of MDA5 dermatomyositis. Moving on to NXP2 dermatomyositis, these patients also have a greater risk for cancer. These patients don't have that much skin disease. If they do, it is mild, but they have more muscle involvement than their NXP2 counterparts, or their TIF1 counterparts. Anti-SAE, these patients have cutaneous involvement. Usually the cutaneous involvement precedes the muscle involvement by a few years sometimes, and these patients usually have ILD, although it is less severe than, for example, the ones we see in MDA5, and they are in greater risk of cancer as well. A few words about the dermatomyositis histology, the skin manifestations. So some of the buzzwords that you're gonna find, the interface dermatitis is inflammatory infiltrate in the interface between epidermis and dermis with the vacuolar degeneration, these white areas here in the interface. are very characteristic, as well as the deposition of mucin, this amorphous glycoprotein that makes the HNE pinker in the dermis. And you can see here as blue in the colloidal iron staining. And these patients may also have perivascular inflammation and the destruction of the small vessels. These findings are indistinguishable from the ones we see in systemic lupus erythematous, and the clinical manifestations and antibodies will help you define to which disease you're dealing with. All right, let's move on to antisynthetase syndrome. So antisynthetase syndrome is a multisystemic disease, usually classified as an idiopathic inflammatory myopathy, although myositis is not always present. The most important clinical manifestations of antisynthetase syndrome is interstitial lung disease. And sometimes it's the only clinical manifestations they have. The hallmark of this disease is the presence of antisynthetase antibodies. And so far, 8 antibodies have been identified. We don't have yet a criteria diagnostic or research classification criteria for this disease. Usually we call antisynthetase syndrome when patients have an antisynthetase antibody and a single or a combination of these features here. Myositis, arthritis, ILD, mechanics hands, Raynaud's, and some patients may have fever as well. These are all the antibodies that we have so far identified with antisynthetase syndrome. And as I mentioned, ILD is the most important clinical manifestation. Anti-Jo1 is the one who was first described and the one who is most common. A little more about antisynthetase syndrome. This is here on your left is what we call mechanics hands, this fissuring and hyperkeratosis of the lateral aspect of the fingers. Usually the thumbs and the first and the index fingers are the most affected ones. And you can see again the combination of the features we have in antisynthetase syndrome. Now let's move on to immune-mediated necrotizing myopathies. This is a condition, an entity that was defined in 2006, so quite recently. And these patients usually have a symmetric proximal muscle weakness with very high elevated muscle enzymes. You're going to be calling to the hospital for a consult because for the diagnosis of rhabdomyolysis quite often, because the CKs can be as high as 100, 200,000. Most patients have antibodies to either one of these proteins, the HMGCR, this huge name here that I'm not going to read it, in the SRP antibody. And usually the titers of these antibodies correlate with muscle weakness and CK levels. There's an important allele that is associated with this disease. And a lot of the patients who have HMGCR, immune-mediated necrotizing myopathies, have been exposed to statin. And statin is a big risk factor for this specific group, the HMGCR immune-mediated necrotizing patients. However, some patients may have the same antibody and being statin naive, even kids. So this antibody can also happen in patients who have never been exposed to statins. And again, clinical manifestations. This is basically mostly a myositis. The myositis can be quite pronounced. Some patients with anti-SRP, as I mentioned before, can have the myocarditis too. Inclusion body myositis. Again, the odd kid in the family has a bunch of different manifestations, very different from the other ones that we discussed so far. These patients have more commonly asymmetric presentation, evolves over many years, and it has that classic involvement, long finger flexors and quads that we discussed. Inclusion body myositis is the most common myositis in patients who are 50 years old or older. Dysphagia is a very common manifestation. And again, the disease progresses very slowly over time, delaying the diagnosis sometimes by many years. We don't know any treatment that works for inclusion body myositis, and it doesn't seem like they respond to any immunosuppressant. There's a lot of discussion, is this a degenerative disease like Alzheimer's is, but for the muscles, or this is a autoimmune disease? Our understanding today that this is an autoimmune disease. We even have an autoimmune antibody for it with degenerative components. We don't know what comes first, but this is an autoimmune disease, again, with accumulation of rare proteins that believe it is related to the degeneration of the muscle as well. Again, this is our figure showing the manifestation of inclusion body myositis with, again, distal involvement and dysphagia. Overlap myositis syndrome. So myositis can happen as a manifestation of many other autoimmune systemic diseases. Systemic sclerosis particularly more common, and these patients can have a quite difficult, quite grim prognosis sometimes. The extramuscular manifestations, again, depend on what kind of associated myocyte overlap syndrome you have. And these patients usually have antibodies against U1 RMP, anti-Cu, anti-PMSCL. These three antibodies are quite common in patients who have systemic sclerosis myositis overlap. And they also more commonly prevalent for the anti-Rho SSA52 kilodalton antibody. Polymyositis. So again, polymyositis was one of the three main categories of inflammatory myopathies as the way we were traditionally thought. And nowadays, we believe this is quite a rare condition. Polymyositis nowadays is a diagnosis of exclusion. After you rule out dermatomyositis, IPM, immune-mediated necrotizing myopathy, antisynthetase syndromes, overlap myositis syndrome, and these patients don't have any particular antibody that defines them in these other beans, then you give the diagnosis of polymyositis. So polymyositis is kind of this trash bin classification at this moment. And again, because of that, is rarer than expected. We believe that a lot of patients who had polymyositis, had been diagnosed with polymyositis in the past, actually have overlap syndromes, antisynthetase syndrome, or immune-mediated necrotizing myopathies that were not well described in the past. And this is just letting you know how things have changed for the polymyositis diagnosis over the years. Initially, everything was polymyositis. And then over time, we found out that some patients had a rash. Then we defined them as dermatomyositis. In the 1970s, we identified inclusion body myositis. So polymyositis group become smaller and smaller over time. And nowadays, they are quite rare. All right, myositis antibodies. I want to dedicate more time to talk about antibodies. And I understand this is really an alphabet soup that is ever growing. And it's important to understand because, as I mentioned to you, these antibodies have a very important diagnostic and prognostic feature associated with them. So understanding these antibodies will go a long way. This is a table with all the myositis-specific antibodies they have described so to date. So again, we have the 8 antisynthetase antibodies. We have the ones that are the dermatomyositis-specific antibodies that we have reviewed. We have the 2 immune-mediated necrotizing myopathy antibodies that we have discussed. Remember, the HMGCR is commonly associated with statin exposure. And we have this last one that really, well, nobody knows yet where to categorize them. Myositis antibodies have evolved quite a bit, particularly in the last 20 years. As you can see here, in the early 1990s, our expectation is that at least 30% of the antibodies were unknown for us at that time. Nowadays, we have way more antibodies described, and our expectation of the antibodies yet to be described has only increased over time. Myositis-associated antibodies, again, these antibodies are present in patients who have myositis, but they also common in patients with other systemic rheumatic diseases, such as lupus, Sjogren's, and systemic sclerosis. And these are, as I mentioned, the most common ones seen in the overlap syndromes. Okay, and here's the table with all of them. I want to mention here a few words about the CN1A. This antibody, again, is the one that we usually associated with inclusion body myositis. However, is not a sensitive antibody nor a specific antibody. It can be seen with many other systemic rheumatic diseases, including in children. Okay, a few more words about antibody testing. Immune precipitation, it is the best way to test them. It's our gold standard technique to check for myositis-specific and associated antibodies. However, it's extremely time-consuming and is really unsuitable for routine testing. So in our regular practice, we use other techniques, usually ELISA and line blots. And these tests are quite good for the identification of anti-Jo1 antibody, but the truth is that they have never been really validated for any of the other antibodies that I talked to you about. So we need validation, and I really want to make something very clear here today, and hopefully you're gonna bring this to your practice from now on. What in a myositis panel for a patient that you are seeing clinic or inpatient, the results of this panel needs to be taken and interpreted with 2 grams of salt. it's very common that we have false positives and false negatives for myositis antibodies. And again, putting together the clinical perspective, a very good, thorough history taking, physics exam, those other testings that we have discussed about MRI and EMGs will be extremely helpful for you to understand how to interpret your myositis panel. Right, so this is again a figure putting together all the myositis antibodies that we have identified so far. And as you can see, things are very dynamic and complex, and different antibodies are associated with different clinical manifestations. All right, I want to talk to you a little bit about histology. Even though we have made great advances in the myositis world with the identification of myositis antibodies, and sometimes we don't even need the biopsies to make the diagnosis, the histology can be quite often very important as well to establish the diagnosis, particularly for patients who don't have any skin involvement and their clinical manifestation is not typical. It's really helpful in identifying the myositis subtypes and also exclude other types of myopathies. So I'm gonna take a few minutes here to talk to you about normal muscle histology. As a fellow, I found quite complicated to be thrown to all these terminologies when it comes to muscle pathology in patients with myositis, and understanding the normal histology goes a long way. So this is your muscle, and around the muscle that is gonna form later on the tendon, we have the epimysium, okay? And inside the muscle, we have this groups of myofibers, muscle fibers. Muscle fibers the same as cells or myocells or muscular cells. So I'm gonna be using them interchangeably, okay? So grouping these muscle fibers or muscle cells together, we have this connective tissue called perimysium. And that's where most of the arteries and nerves are coming in and out of the muscle. Now zooming in, inside the fascicles, we have each one of the muscle fibers or muscle cells, and the connective tissue in between the muscle fibers is what we call endomysium, okay? And inside the muscles, going inside the muscle fibers or muscle cells, we have the cytoplasmic membrane, the one from the outside that we call sarcolemma, and the cytoplasm inside is called sarcoplasm, okay? So that's how we understand the muscle histology nowadays. Let's zoom in inside the muscle fiber itself. Again, this is one muscle fiber, and the muscle fiber is this long, very big muscle cell that is multinucleated. Usually the nuclei are in the periphery. And inside the muscle fiber, we have the myofibrils, which are the composition of actin and myosin. And the actin and myosin are the ones that are actually the functional part of the muscle, the ones that cause the muscle contraction, okay? So I hope that was able to clarify some of the nomenclature you may have read so far. Okay, I'm gonna give you some buzzwords here. The dermatomyositis is the one that is associated with inflammation and atrophy in the perimysium. So let's come back here. Again, perimysium is the connective tissue that it surrounds the fascicle. That's the one that is affected by the dermatomyositis, and is usually around where we see the vessels coming in and out, okay? So perivascular, perimysial inflammatory changes. Polymyositis, on the other hand, affects the endomysium. So endomysium here is the connective tissue in between the muscle fibers, inside the fascicle itself. That's where the inflammation is happening. And this, in polymyositis, you have mostly cytotoxic T cells. As T cells surround and invade muscle fibers. Immune-mediated necrotizing myopathies, guess what? We see a lot of necrosis, and the necrosis is scattered, does not really follow any pattern. And around necrosis, we also see regenerating muscle fibers. In antisynthetase syndrome, is usually perifascicular, as is the case with the dermatomyositis, but we also see a lot of fragmented perimysium. The connective tissue becomes looser in antisynthetase syndrome. Inclusion body myositis patients, the endomysium is affected, very similar to the polymyositis with those surrounding cytotoxic invading T cells as well. But we also have differently from polymyositis, these rim vacuoles, these agglomerations of misfolded proteins, they're rimmed, and this is the hallmark of the histology inclusion body myositis. These are some examples. Again, this is the perimysium of a patient. Perimysium, this is where the artery is supposed to be, and you can see this purple, increase in purple here is all inflammatory cells attacking the perimysium and the areas around the fascicles. Okay, this is all the dermatomyositis. And this is here an antisynthetase syndrome with this fragmentation of the perimysium, looks very loose. And I definitely encourage you to take a look later on different pathologies that unfortunately we won't have time to go over here, but will be very important for you to understand, again, to reinforce the nomenclature that we discussed. Just one more, this is a patient with polymyositis, and you can see again the endomysium in between the muscle fibers affected, and some of these T cells actually inside the muscle fibers attacking muscle fibers. Right, let's talk about classification of inflammatory myopathies. So again, a word about classification criteria in clinical diagnosis. Your preceptors at your fellowship training program may have mentioned to you already. Our diseases, most of them have classification criteria, which are focused and were developed to allow for a homogeneous population to be enrolled in clinical trials. They can aid to the diagnosis and work as a framework to the clinical diagnosis, but a lot of times the clinical diagnosis goes way beyond what we use for research classification criteria, okay? So the classification criteria so far, the last one we had is from 2017, and it has been limited to the diagnosis of dermatomyositis, amyopathic dermatomyositis, polymyositis, juvenile myositis, and IBM, whereas, again, we have talked about other types of myositis as well, the overlap syndromes, immune-mediated necrotizing myopathy, antisynthetase. And the classification criteria nowadays is very restricted to specific clinical manifestations, muscle enzymes, and muscle biopsy findings. The only antibody of all we have reviewed so far that is included in that classification criteria is anti-Jo antibody. Whereas for the clinical diagnosis, again, we have a variety of antibodies that can help us with the diagnosis. Nerve conductive studies, EMGs, and muscle MRIs can also aid to the diagnosis. Okay, and this is showing to you how things have evolved, again, another timeline in the world of inflammatory myopathies, how things have changed in very recent times. And unfortunately, most of the training, most of what we learn about inflammatory myopathies is around here. Is the late 1990s and early 2000s, when the only clinical subtypes of inflammatory myopathies that we had were dermatomyositis, polymyositis, and IBM. This is the current algorithm for the classification criteria, again, for research purposes that can be used as a framework for diagnosis. So if patients are younger than 18 years old, they have a juvenile type of myositis, which was not the focus of this talk today. If patients are older than 18, and they have a rash, well, then they have dermatomyositis. And the question is this amyopathic or not? And if they don't have a rash, they can be diagnosed with IBM based on muscle biopsy features and clinical features, or polymyositis. And the group already recognizes that, hey, a lot of these polymyositis patients probably have immune-mediated necrotizing myopathies, which we understand nowadays, but do not understand a few years before when we were developing these classification criteria. This is the scoring system currently being used for the classification criteria. And again, way more complex than the classification criteria is how we actually get to the clinical diagnosis of this patient. And I don't want to go over step by step here, but this is just an overview that after seeing a patient with elevated CKs and muscle weakness, serologic testing, MRI, EMGs, and muscle biopsies are all used together for the diagnosis of inflammatory myopathies. The differential diagnosis, again, this is not the focus of our presentation today, but it's quite important. A lot of patients come to us for elevated CKs and muscle weakness, and it's our job to rule out other possible non-immune related diseases that can be causing these conditions, in particularly muscle dystrophies, and I want to make a point here, the muscle dystrophies are not restricted just to children. Adults can be also newly diagnosed with muscle dystrophies. Metabolic myopathies, enzymatic defects in the mitochondria and other organelles can cause very similar presentations. Endocrine myopathies, hypo and hyperthyroidism, hypercortisolism, hyperparathyroidism can be also affecting the muscle function. And toxic myopathies are quite common. Patients use specific kind of herbs. They use fungi that can cause mushrooms that can cause specific myotoxicities. So a very good, thorough history goes along the way. All right, a few words about treatment. We don't have guidelines. Okay, we don't have guidelines. A lot of what we talk about treatment, including what we're talking today, it is based on experts' opinion, and there's a huge unmet need for new therapeutic approaches. Most of the treatments rely on high-dose glucocorticoids plus some type of immunosuppressive medications. So I just want to mention here, this is the usual framework. Again, depending on the clinical manifestations, those extramuscular manifestations that I mentioned to you, we may decide to use one specific steroid-sparing agent compared to another one. So we use methotrexate, azathioprine, mycophenolate quite often. I like methotrexate for muscle and joint disease. Mycophenolate always for patients, is always my first line for patients who have diagnosis of ILD as well. And we may add on rituximab, cyclophosphamide, tacrolimus if the patients have very severe disease. The good news is that in 2021, IVIG was approved by the FDA for the treatment of dermatomyositis, which is huge hallmark and the only medication that is FDA approved for our diseases, okay? Other agents such as tofacitinib, a JAK inhibitor, has been shown to be beneficial in some types of MDA5 ILD, as I mentioned, or refractory disease. Some folks have tried as well abatacept, although the most recent clinical trial has failed. Again, sometimes being a myositis expert is being a little creative in how we are going to use these medications that are still off-label. And this is just an algorithm on how we approach refractory myositis. As you can see, IVIG, it is still a core medication that we can use in patients who have refractory disease, or a first-line agent for patients who have dermatomyositis as well. Again, IBM, the odd kid, does not respond to immunotherapy. You may try glucocorticoids initially for the treatment of IBM, and they may decrease the CK levels a little bit, but the truth is that we don't believe that this is a long-standing response to immunosuppressive therapy. Exercise at this moment is the only treatment option for inclusion body myositis patients, unfortunately. Exercise and physical activity. A lot has been said in the past that, well, I was told by my physician, I was told by my rheumatologist that I cannot exercise because I have a myopathy, I have inflammation in my muscles. This is really wrong. We understand it the opposite nowadays. We know that these patients can still and will respond to exercise, and they should start exercising as early as possible, even when the disease is still very acute in presentation and diagnosis. And we know that these patients have improving aerobic response, capillary growth, and muscle remodeling when they exercise, and exercise may also decrease the inflammation in the muscles, which is very cool. So again, exercise is part of your treatment here from the beginning, from the get-go. Whew, I think that's it. I hope I didn't exhaust you all, and I'm here to answer some questions.
Thank you, Dr. Bauer-Ventura, for that tremendous review of the idiopathic inflammatory myopathies. Before we move into the question and answer session, could everyone please fill out this 2-question survey? It will really help us to refine our lectures. And once everyone's done that, we'll move on to the question and answer session. Okay. So to start off, I had a question about patients with SRP antibodies and sclerosis myositis overlap. You mentioned they often have cardiac involvement. In patients who don't have any specific cardiac symptoms, do you regularly screen these patients? And if so, what modality would you use to screen them?
Yeah, this is a very interesting question. I don't usually screen, and most experts will not screen unless there are any concerns of cardiac involvement clinically. So again, it seems that most patients, even if they do a cardiac MRI, they will have a subclinical disease. And we don't really believe that the subclinical disease will have an impact in the prognosis. But again, this is an area of unmet needs. We have not really investigated in depth how these patients evolve over time. But at this moment, there are no recommendations for screening unless there is a clinical concern of cardiac disease.
Thank you for that answer. Another question, can exercise increase the muscle enzymes? And if so, how would you differentiate between a relapse and exercise-related muscle enzyme elevation?
You can have a mild increase in CKs if patients are doing very strenuous work. But this is really not the case in patients with myositis. Most patients do mild to moderate exercise and they increase it over time. And even if as they engage in more active physical, engage in more physical activity over time, I don't expect the CKs to be significantly elevated to the point I'm concerned about a flare. If a patient is having a flare, remember the CKs being elevated is not enough for me to understand a patient is having a flare. I must see other signs of clinical disease activity as well. So these patients will complain to you that the muscle weakness is actually getting worse, not better, and they are therefore unable to exercise as much as they were exercising before. So again, putting together the CKs, which can be elevated a little bit with activity, but I would not expect these patients to be doing as well from the muscular perspective if they were having a flare.
In terms of treatment with IVIG for dermatomyositis, now that it's FDA approved, are you often going to that first line when someone's initially diagnosed, or are you exclusively holding that for refractory disease? And if you are using it first line, how do you decide to start?
Quite often, I use it first line in addition to steroids. There are ongoing studies now on the use of IVIG without steroids, which is very exciting. It may be a recommendation in the future, but I usually recommend IVIG right at the bat if patients have very extensive skin disease, if patients have dysphagia from the get-go, from the diagnosis, in patients with active muscle disease as well. What I'm trying to say is that I rarely ever, if I ever did, steroids alone. I usually associate steroids with something else, and now that IVIG is FDA approved, IVIG is my first line in many patients.
Okay. How would you interpret a patient with slight elevation in muscle enzymes without obvious muscle weakness and negative serologies?
This is a very good clinical question. I get these referrals at least 2 or 3 times per month. So I do a very thorough evaluation. A lot of times I recommend them to have EMG with my neurology colleagues who are really exceptional in doing EMGs. And again, identifying if there's any subclinical mild form of myopathy that I missed doing my phys exam. And again, if the antibodies are all negative and I don't see any other signs of extramuscular manifestation, it's only the elevated CK, I look for, again, is there any medication that can be associated with the elevated CKs? Things such as colchicine sometimes can cause a myopathy. There are also HIV medications that can be associated with elevated CKs. Again, those endocrinology diseases, they also should be screened. So I will go over our differential, ruling out toxic metabolic diseases that can cause elevated CK. And if everything is negative, EMG is negative, muscle enzymes, serologies are negative, identifying any toxic or metabolic component, and the elevated CK is mild, I ask the patients to come back and follow up with us in a little bit, because chances are, even if I do a muscle biopsy, we'll probably not yield to any diagnosis. However, if there is muscle weakness and the CKs are elevated, and I have not been able to categorize this patient according to our subtypes of inflammatory myopathies or the metabolic and toxic myopathies, I sometimes send these patients to neurology for evaluation of metabolic myopathies. And in this case, additional genetic testing in muscle biopsies may be recommended if patients are having muscle weakness.
Excellent, excellent. Well, I want to say thank you so much to Dr. Bauer-Ventura. We really appreciate hearing from you and hearing your expertise on this topic. I did want to put a quick plug in for our next session on Thursday of this week on the 11th from 10:30 to 12:30. The topics will include fibromyalgia, chronic musculoskeletal pain, and Sjogren's disease. So everyone, please consider attending on Thursday, and we will hopefully see you again on Thursday. And thank you so much again.
Wonderful. Thank you so much for the invitation. Have a wonderful day. Take care.